Morning. Well, thank you. Welcome to St. Luke's Physical Therapy Grand Rounds. Today we have Jeff Hashagen with us. He earned his bachelor's and master's at Misericordia University in physical therapy, and he is treating patients at our Macungie site. So without further ado, I will turn it over to Jeff.
Thanks. Good morning, everybody. Anybody here treat lymphedema patients at all? Okay. Anybody here ever see patients with lymphedema? Okay. How do you know they had lymphedema?
Big and swollen.
It's usually your first sign. Okay. Most people look at lymphedema patients and they see big and swollen and they wonder why. Okay. Predominantly here in the United States, it's because of cancer. But actually, more of my caseload I've been seeing lately, it hasn't even been cancer cases. Okay, so I'll get a little bit into that today in the presentation. Anybody has any questions even throughout, just raise a hand. Okay, any questions with the slides, I'll be happy to answer as we go along. Today I want to introduce you more just to some of the science of it. We'll talk about a healthy lymphatic system, okay, and then we'll also talk about some of the issues that can compromise the lymphatic system. Okay, so as Steve said, I'm practicing with lymphedema. I'm a certified lymphedema therapist. If you're referring somebody for lymphedema treatment, that's one of the things you want to look for. It's either CLT and then even a CLT or LANA is what you want to look for. It means these people have been trained through one of the 4 schools in the United States that are offering education on lymphedema right now and offering certification. Okay, it really guarantees they're going to get the highest standard of care. All right, and we'll get into that and what that involves through the presentation. All right, so we'll click along here. Click. Okay, we'll use this. So first off, disclaimer, I am not financially bound to any of this. Okay, and then we get into lymphedema. The definition, it's an abnormal collection of high protein fluid, and this is a key component we'll get into. Just beneath the skin, it's occurring most commonly in the extremities, but a lot of people don't realize it also occurs within the trunk, the breast, the head, neck, or even the genitals. Okay, the development occurs when lymph vessels are damaged or lymph nodes are removed. A lymphatic system review. It's a network of tissues and organs that help rid the body of toxins and waste material with the primary function of transporting lymph, which is a fluid containing protein and white blood cells throughout the body. The superficial lymphatic system extends to the dermis. It's not a closed system of circulation. It works to remove lymphatic loads. It's a mixture of protein, water, cellular components, particles, and fat. Your lymphatic system starts to develop at gestational week 5. Okay, so it really starts to develop early on. And just a tidbit here, each person's lymphatic system is large enough that stretched out, it reaches the equivalent of 60,000 miles. Or as I always tell patients, enough to go round trip from New York to LA 10 times. Okay, just one person's lymphatic system. That's how involved the system is. It starts with lymph capillaries. Okay, these are initial lymph vessels. They're larger than blood capillaries, and they begin the lymphatic drainage system. The capillaries form a mesh-like system, and then it forms into the precollectors. The precollectors connect the lymph capillaries to collectors. They're embedded within the subcutaneous fatty layer of tissue. They start to contain valves. Think about these two when we talk about the methods of treatment. Most people are surprised at how light and gentle the treatment is actually performed, but when you understand the anatomy, you get a better understanding why. Important to know that both lymph capillaries and precollectors consist of endothelial cells. Fluid can enter the capillaries that are precollectors, but it also can exit the capillaries or precollectors. This is where fluid can kind of get caught up. Once it goes into the collectors, they start to contain valves, and now it becomes more of a one-way system. It's all moving proximal. The lymphangion is a segment between the distal and proximal valves of a collector that aid in lymphangiomotoricity. My patients love this term. All right. With an automatic contraction rate of 10 to 12 contractions per minute at rest, and ability to achieve 60 contractions per minute when needed. From the collectors, we move into lymphatic trunks. These have the same wall structure as collectors, but they're more developed and they have musculature within the media. They're both innervated by the sympathetic nervous system. We then move on to lymph nodes, okay? And this is what we're most common with seeing removed for surgery and those types of things in a lot of our cancer care cases. The three main functions are going to be protective. They filter harmful material. Immune function, responsible for production of antibodies. They circulate white blood cells. And the thickening of lymph fluid. There's blood capillaries within the lymph nodes that help to remove some of the fluid within the lymph, and it actually thickens the fluid and helps to reduce the amount that has to be pushed back through the lymphatic system. So your blood capillaries really help out along the way with your lymphatic system. The predominant regional lymph nodes that we focus on for treatment are going to be in the axillary and in the inguinal regions. Your lymphatic trunks drain fluid through the body, leading to the thoracic or the right lymphatic ducts. These are kind of your two main highways or pathways that are going to help to lead things back to where they need to go. Your jugular trunk consists of your head and neck. Your supraclavicular trunk is going to manage your head, neck, shoulder region, and mammary glands. Subclavian trunk, the axillary lymph nodes, bilateral upper extremities, upper quadrants, including your mammary glands. Your parasternal trunk takes care of the chest and abdomen, including the deeper viscera. And the lumbar trunk is bilateral lower extremities, external genitalia, and the lower body quadrants. Again, I mentioned the right lymphatic duct and the thoracic duct. Okay, going to be the two main pathways we're really trying to direct our fluid. Your thoracic duct manages 3/4 of the body's lymphatics. This includes your left and right lower extremity, your left and right lower quadrant, your left upper quadrant, your left upper extremity, and the left head and neck. So the entire left side of the body, okay, and then the right lower body. It's the largest diameter lymph vessel in the body. It's between 1 and 5 millimeters. It originates at the cisterna chyli, right about level of L2 to T11. This is milked by the diaphragm. Okay, the thoracic duct cuts through your diaphragm, so we emphasize diaphragmatic breathing with a lot of these patients. Okay, because diaphragmatic breathing is something patients can be doing on their own at home. It's also an application for our treatment to help force fluid up through the thoracic duct. Your right lymphatic duct manages the other quarter of the body's lymphatics. This includes the right head and neck and the right upper quadrant. Watersheds. These are boundaries. These are pivotal to treatment, and understanding them is key. All right. They're linear areas of the skin that separate territories of the body, directing the flow of lymph fluid. You have your mid-sagittal, okay, cutting right through you. Your transverse, all right, through the abdomen. Clavicular, spine of the scapular posteriorly, and your chaps or gluteal region. Anastomoses. These are even more important in treatment considerations. These are interconnections between territories of the body. You're crossing watersheds that aid in the movement and reduction of lymph from an affected region to a healthy region. Your anastomoses are defined by your anterior and posterior axilloaxillary, anterior and posterior interinguinal, left and right inguinoaxillary, and left and right axilloinguinal. So, so let's say I have a patient with a right lower extremity lymphedema. Okay, we're in a quadrant now. We're kind of stuck from basically lower abdomen down to the right leg that is affected, and most likely it's the right inguinal lymph nodes that are affected. So I want to promote movement of fluid to my healthier regional lymph node beds, okay, which would be my right axillary and my left inguinal. So I need to cross these watersheds, and I utilize the anastomoses. So my interinguinal, okay, and my inguinal axillary anastomoses are what I'm going to work on. This comes into more consideration with treatment. You'd be surprised. About manual lymph drainage is about 45 minutes long for one limb, and I probably spend 25 minutes clearing the rest of the body before I even get to that limb. And we'll talk more about that as we go. So just a quick review of the physiology. Follow the lymphatic road here. You start with a lymph capillary, and it moves to the pre-collectors, then it moves to lymph collectors. Travels to your lymph nodes. Fluid is going to be better processed here, and then it moves through more lymph collectors to your lymph trunks. It then moves to your lymphatic ducts, going to be the thoracic or the right lymphatic, and then to your venous angles, right or left. This is formed by the internal jugular and the subclavian veins. and then return to your venous system. Understanding lymph flow versus blood flow. Blood flow is circular. It moves at liters per minute. Moves at liters per minute. Lymph flow is one way. It moves at 1 to 2 liters per day. Okay, so understand that the movement of lymph flow is much slower. Okay, you know, it's funny when I come out of my treatment room and I see my secretary scheduling an emergency evaluation for lymphedema. I said, well, lymphedema is generally not an emergency. Okay, it's something that is slow developing over a period of time. Some of these more emerging considerations where patients are sent to me because they have a sudden onset of swelling, we're concerned about infection, okay, or it's not lymphedema, it's congestive heart failure or something like that. Usually they've got to be cleared by their cardiologist before they should even see me for treatment, okay. So keep in mind that when you see a rapid and sudden onset of swelling in a limb, it's most likely not lymphedema. There could be a component of that, but you want to rule out your other complications first, and we'll get into that then. Starling's law, I just threw this in here. It's kind of the understanding of arterial blood capillary pressure, colloid osmotic pressure, and venous blood capillary pressure. Starling basically said that there's going to be an even calculation here, 25 millimeters of mercury across the board. But what he didn't really consider was some of the external forces that are involved. Okay, the forces of equilibrium are going to be blood capillary pressure, colloid osmotic pressure, the pressure of the protein, colloid osmotic pressure of the interstitium, and interstitial pressure. The fact that they're variable is something that will affect Starling's theory. The significance of this is that there's variations in forces that will affect the flow, including venous return and lymph production. Key terminology here when we start understanding lymphatic loads, all right? Transport capacity is the total capacity or amount of workload the entire lymphatic system can perform over a unit of time. Okay, this is 10 times that of the lymphatic load. Your lymphatic load is the workload or the amount of lymph fluid. How much you just have fluid is there to move throughout the day. Functional reserve is the difference between your transport capacity and your lymphatic load. So how much more reserve do we have that your lymphatic system can manage? And lymph time volume is your safety valve function. It's the maximum lymph time volume that is equal to transport capacity. So this really comes into play when we understand sufficiency versus insufficiency. In a sufficient lymphatic system, there's a generous functional reserve. You have plenty of extra space. You can invite all the relatives in. You can fit them all in. All right. Elevated transport capacity, it is fine. Functional adaptation to demand, vital lymph time volume, and you don't have any edema. But in cases of insufficiency, understand you're going to have 3 types: mechanical, dynamic, and combined. This is important, especially when you're looking at diagnosing a patient properly. Your dynamic insufficiency is a high output failure. Okay? Your transport capacity, your total capacity, is exceeded by the lymphatic load. So your transport capacity is remaining at normal. Nothing is affecting that. Essentially, you still have a healthy lymphatic system. The functional reserve is now absent because your lymphatic load has just exceeded your total capacity. The edema is a low protein. These are more examples of what we call high water edema. In these cases, you're going to see much more pitting. You're going to see more fluctuation in the amount of swelling or volume of the limb. Examples of this could be chronic venous insufficiency, deep vein thrombosis, congestive heart failure, malignancy, or hypoproteinemia. Mechanical insufficiency. This is more when you're looking at a lymphedema issue. All right, this is high protein edema. Okay, your transport capacity is lowered and subnormal. Okay, so you have less room to work with. You have a much reduced functional reserve, and your lymphatic load doesn't have to get as high to exceed your transport capacity. Example of this are going to be primary and secondary lymphedema. All right. Combined insufficiency is going to be a combination of both dynamic and mechanical. Okay, your lymphatic load exceeds the transport capacity. The transport capacity drops, and you have a mixed edema of high water and high protein. This is more phlebolymphostatic lymphedema, lipedema, and malignancy. The best analogy I use to describe this to patients, because I see a lot of patients with this, is imagine you have a sump pump in your basement, and you're smart, you have a smaller backup sump pump. When we get a huge rainstorm, all right, and your main pump, it burns out, okay? Your little pump takes over, and you don't even realize, because the little pump is doing its job. But every rainstorm, because you never realized that your main pump kicked out and you never replaced it, every rainstorm that little pump is doing the work of the big pump. Okay. Now the little pump tires out, and now your basement fills with water. Okay. The big pump is your venous system. All right. You have a venous compromise. Maybe it's a DVT, chronic. It's distended the veins. The veins are no longer functionally optimized and removing your lymph fluid. Removing fluid, and it starts to back up, and that's high water. Okay. So your lymphatic system says that's fine. We can manage that. And it starts to pump that out. Okay, but over time it's doing more and more work and more work, and it just gets tired, and it can no longer maintain that load, and now the lymphatic system tires out, and you start having a backup of fluid. Okay, when I usually put that analogy in patients, like, you know what, that makes sense. So the gold standard for treatment, how do we manage patients with lymphedema? Okay, I don't have a slide in here, but I will define in case people are not. Primary lymphedema is you're born with it, okay? There are children, and sadly there are cases out there. Children are born with this. They develop it from infancy just to age 1, okay? And they're told by some doctors there's nothing you can do. There's nothing you can do. You just have to manage it and live with it. And we've seen cases of children that are walking around with these huge edematous limbs, okay? And it's not true. Obviously you can treat it, okay? And we'll get into that. Secondary lymphedema, the number one cause in the world is filariasis, which is an infection spread by mosquito. We see this in not just third world countries, but countries closer to the equator. Okay? In the United States, of course, you Google lymphedema and Susan G. Komen Foundation comes up, and so related to breast cancer. And then I have men that come to me and they say, well, why do I have lymphedema? I don't have breast cancer, or, you know. And I say, well, it's a lot more related to that. The most common thing we see it related to is the removal of sentinel nodes or lymph nodes with breast surgery related to cancer. I also see it very commonly, a lot of women that had hysterectomies, predominantly in the 70s and early 80s. It seems like a lot more lymph nodes were being pulled with the hysterectomies then, and then they start to develop this. The average onset I see after insult to the lymphatic system is about 3 to 5 years. Okay, so I have patients that come to me and they say, well, why didn't anybody educate me about this? Why didn't anybody talk to me about this? Okay, and I say, well, if you had cancer, the main focus was, well, let's treat the cancer. Let's keep you alive. And then oftentimes it's an afterthought, and it's, well, there's the slight risk you could develop this. Maybe there's a pamphlet or a little bit of education given to the patient, and they kind of forget about it. And then gradually their limb starts to just feel tight, maybe a little band-like, maybe a little sore or kind of heavy, okay? But they still don't notice much of a difference. And then gradually this inflammation builds up and builds up and builds up. It's not one of these situations where you wake up one morning and it's like, whoa, my whole arm is swollen or my whole leg is swollen. So oftentimes patients aren't even aware until it's already gotten into a point where they're really having an issue, okay? So one of the most important things we can understand as clinicians is education. Patients should be educated from the get-go. If you have any insult to your lymphatic system, to your lymph nodes, okay, you are at risk. And it's not just cancer cases. There's orthopedic cases. People with joint replacements are at risk. Okay, any surgical intervention where there's a cut made, okay, you can be cutting through the lymphatic system and compromising it. Okay, there's also primary lymphedema, lymphedema tardum, where people are born with it. It doesn't come on at early onset. It develops later on in life. Okay, and sometimes there's a surgery or an insult to it, and it kind of exacerbates it. Okay, so understanding that even if you're trying to diagnose a patient, you don't find a direct cause, like, oh, you had cancer surgery, you had a mastectomy and lymph nodes were removed. Sometimes it just comes on later on in life. It's rare, but it does occur, and I have a patient right now that I'm treating that happened. Okay, so it's a little complicated when you're diagnosing these things. So we'll talk about what we do for it. All right, complete decongestive therapy. It's considered the gold standard in treatment. There's no medication to treat this right now. The University of Stanford is working on a medication. Right now they're seeing an excellent reduction in the tails of mice. All right, so that's how far we are from human trials yet. Okay. Manual lymphatic drainage, compression bandaging garments, remedial exercise, skin care, and patient education are all a part of complete decongestive therapy, okay, or CDT treatment we call it. Understand the train car effect. I always tell people, if you want to move a train, are you going to push from the caboose or are you going to move the engine? Okay, you want to move the engine first and then the following train cars. Most clinicians, and for years I'd always think, oh, if you saw an edematous limb, you want to start at the toes, you want to start at the fingers, and push that fluid up and out of there. It's the worst thing you could do. And I have patients come to me, no, I had treatment. Well, how'd they do it? Oh, well, you know, they started at my toes. I said, nope, stop right there. They already did it wrong, okay? You want to clear everything, okay, before you get to the edematous limb. So I start at the neck. The first thing I do is I come in, it looks like I'm choking my patients, okay? But I'm clearing the venous angles, okay? Then I will I'll do my diaphragmatic breathing. There's an abdominal sequence. There's some contraindications to that you don't do with the patient if they have a history of abdominal issues, okay? Understanding that this is very light, it's gentle. You do not apply a deep pressure or glide across the skin. You want to capture the skin and provide a slight, gentle stretch. And that applies to the fact if you go all the way back, understanding the anatomy of the lymphatic system, those lymph capillaries have these little branches or attachments that kind of attach them to the skin, these myofilaments. And you're basically promoting a stretch of those, and that's opening the lymph capillaries and allowing the fluid to go in there. So it's very, very gentle, it's very light. And this is also a great consideration for those patients that are dealing with cancer, have active malignancy. If it's guided by their physician, it's advised that they go for treatment because they find it very therapeutic. It's relaxing for them. Patients that even have complex regional pain syndrome or ISD, they find it very relaxing, okay, and soothing because it's not a deep technique. The manual lymph drainage follows a very specific pattern, as I was discussing. This is based off the Water technique, which was original in Germany, okay? And the average treatment time for one limb is 45 to 50 minutes. So a lot of my CVI patients, it's bilateral lower extremity. I'm in there doing manual lymph drainage for about an hour and a half, okay? It's tiring sometimes, all right? But the benefits of this are volume reduction, you get an analgesic effect, and reduction of skin fibrosis. After I perform the manual lymph drainage, I put patients into compression bandages, okay? This acts as a primary source of containment. There's a high working pressure and a low resting pressure. Emphasis on law of Laplace. You utilize soft stretch bandages, okay? There's variance in foam. Some insurances cover supplies, Medicare does not, okay? Supplies are ordered by the patients. Bandages are washable and can be used an average of 3 to 6 months. They're utilized in the acute stages of care or phase 1. I educate patients in self-bandaging. And eventually I'm going to transition into compression garments. A key component I cannot stress enough, I have patients that are sent to me. My doctor told me just use an ACE bandage. Don't ever have one of these patients use an ACE bandage. Elasticity is not your friend here. Soft stretch bandages look just like ACE bandages. When you go to pull on them or stretch them, they don't stretch like an ACE wrap, okay? They're short stretch, okay? They don't really stretch a whole lot. And the problem with that when you use an ACE bandage is you're not getting an even compression gradient. You're going to be creating a tourniquet effect for these patients, and it's not going to allow the flow of fluid. Okay, so you always want to use a soft stretch or short stretch bandages with these patients. Don't ever put them in an ACE wrap. Okay. The other big thing here, high working pressure and low resting pressure. Again, ACE wraps with that elasticity are going to have the opposite. Okay, so when a patient is sitting and resting, that ACE wrap is going to be putting a high pressure on the area. Okay, again, creating that tourniquet effect. Where these other bandages here, when they're resting, they have a low resting pressure. But when they're working, quote unquote, remedial exercise, getting up, walking around their home, you're exerting a better pressure and helping to promote lymphatic flow. Okay, so that's the big difference in understanding with the compression bandaging. When we talk about compression garments, there's a wide range of prices here. Okay, off the shelf is obviously going to be cheaper. custom is going to be less expensive. Although in a recent meeting I had with a DME provider, they informed me that Medicare will not cover for off-the-shelf garments, but they will cover for a custom garment, which sounds kind of silly. They're spending more money, but Medicare seems to be good at that sometimes, okay? So if we want to get one of our patients into a custom garment, great, Medicare will cover it. Off the shelf, you're trying to save some money, apparently they won't cover it. Flat knit versus circular. Circular oftentimes are going to be more like the cheap TED stockings you can get, okay? It refers to how they're made, okay? They don't provide as much of a compression level when they're circular, okay? They're cheaper and they stretch easier. A flat knit, you're going to see some seams in that. That's the big difference, okay? And that's how you understand. There's some seams there and it provides a better compression, but they're going to be more expensive, okay? This is generally the standard I try to use when I'm getting garments for patients, is the flat knit. There's multiple options to address all different regions of the body, even including the head and neck. There's nighttime versus daytime garments. As a certified lymphedema therapist, we're trained to fit patients, but also there's a lot of garment companies out there that have certified fitters that will come out and fit your patients for this as well. The average warranty and life of a garment is 6 months. This is important to explain to patients when you're initiating treatment. It is expensive for these garments, and they don't all have insurance coverage on this. And getting them to understand that this is a lifelong condition that they are being treated for. Lymphedema is a disease. It is not a symptom. You don't beat lymphedema. You manage lymphedema, okay? So getting patients to understand they should be following up with a clinician every 6 months to be refitted for garments, okay? There's all different compression levels, okay, ranging from 23 millimeters of mercury to 50 plus. On average, I'm putting anybody in garments starting as low as 15 millimeters of mercury to 20. I'm usually between a 20 to 30 range to start patients out. A lot of them have a hard time clearing bony prominences or getting the garments up around their ankle or up over their wrist. So that's a consideration. It's best when they have a spouse or somebody that can help them put their garments on and off. But there's also some aids out there that you can purchase to help put these garments on. The most important thing for me is patient education. When I evaluate a patient, I spend about an hour with them, okay, just explaining to them what lymphedema is and going through what they need to be doing, okay. The most important thing is skin care. Patients need to be checking their skin daily, okay. They're at a very high risk for infection, predominantly lymphangitis, okay, and cellulitis, all right. So they need to be checking their skin. They need to be applying lotion daily. They can be self-bandaging. You can teach them on self-manual lymph drainage, especially if they're having edema in their genital region. Okay, this is an area we predominantly don't really do manual lymph drainage as clinicians, but we can educate patients. We even have a video that they can take and watch so they can be performing self-manual lymph drainage. Okay, it sounds crazy, but there are men that will literally have so much lymphedema in their genitals, it's the size of a basketball. Okay, so imagine a patient having to try to go through that. Okay, to move, to get up and walk, it's very tough. Remedial exercise is key for patients. For some people, it's having a fitness routine. For other people, it's just getting up and going for a daily walk. All right. Healthy nutrition. This is kind of, some people agree with this, some people don't. People always want to know, is there something better I could do? Could I do a low-salt diet? I mean, anything will help, but really the research out there suggests that there's not much of a difference affected by diet in your lymphatics. Okay. But there's some people out there that are making the claims, and the research is kind of progressing. Risk reduction, predominantly for reducing infection. I had a woman I evaluated the other day. She had these tremendous folds around her knees. When I'm evaluating, I've got to look through all those folds, and I found an open sore, and she didn't even know it was there. And I said, hey, we got to get this treated. We treated within a week, it was gone. Okay, but when you have that, you're at a very high risk for infection. She didn't even realize it was there. Diagnostically, okay, when we're diagnosing patients, sometimes it's confused, okay? You know, patients are sent for lymphedema and it turns out they have chronic venous insufficiency, or patients have lipedema. Lipedema, okay, I'm going to just touch on it. A lot of times these patients look like they're two people in one. Maybe they have a much smaller waist, but they have very large lower extremities, okay? And that's most commonly the presentation. There's generally not a foot involvement with this, okay? So see these very large extremities and then little feet, okay? It just stops right at the ankles. I do have a case right now where it's a lymphedema. The patient has lymphedema, but it also turned into a lymphedema case, all right? So she's always going to have larger legs, all right? But I've been treating her and I've been seeing a tremendous reduction because she has so much lymphatic fluid also built up in those legs because the lymphedema was compromising her lymphatic system, okay? But in lymphedema, it's generally painful for these patients. The skin is much softer, the tissue is softer and more lumpy, or we kind of, that cottage cheese effect, okay? It doesn't look as solid. So you want to understand the differences there. And then again, usually the smaller waist is generally not affecting the upper extremities. This is typically more in the lower extremities. Congestive heart failure, okay? I'm not treating these patients. I could if I want to lose my license to practice and I want to kill them by the end of the week, okay? When patients have congestive heart failure, and they're really seeing an increase in fluid, generally you're going to see more pitting in the legs. I've literally had patients come in and the water is just seeping from their legs, okay? I had a horrible case. A patient was seen by his family doctor, just kept providing Lasix, okay? It wasn't really doing anything. He was in to see his dermatologist. His dermatologist sent him to his podiatrist, who's actually a good friend of mine, and they emergency sent, oh, Jeff treats lymphedema, we'll get him in. So the guy's son brings him in and says, you know, yeah, can you treat him? And I said, absolutely not. Get him to his cardiologist yesterday, okay? He got him to his cardiologist. His son called me from his cardiologist's office and said, thank you. He said, we're meeting with the heart valve replacement team. They're admitting my dad to the hospital. He's getting a heart valve replacement, and they're medically managing the reduction of the fluid from his legs, okay? Again, when it's that acute, you have that sudden onset, and it's that severe, and you have the high pitting, odds are it's not lymphedema. You got to look at a different direction there, and oftentimes it's congestive heart failure, okay? Also, renal insufficiency, hepatic insufficiency, and malignancy. I go through an extensive health history with these patients. You want to trace back as far as you can. Have you ever had any compromise of your kidneys, of your liver, any cardiac history? Those are the areas you really want to clear before you initiate treatment with these patients. Contraindications to complete decongestive therapy. Acute infection. You can spread an infection by promoting lymphangiomotoricity. If you have a cellulitis or a lymphangitis and you initiate treatment, you're going to spread their infection. They can become septic and you can in turn kill this patient, okay? However, if the patient is sent and they're on antibiotics, within 48 hours of being administered antibiotics, good news, we can start treating them. They're cleared to be treated, okay? Congestive heart failure, I already discussed that. Renal failure, again, you're going to overload the kidneys. Acute deep vein thrombosis. Acute deep vein thrombosis. If a patient has had a history of DVT, that does not preclude them from treatment. You can still treat them, okay, but you want to not treat them if you have acute DVT. Again, you can mobilize that. And malignancy. Now this really, we put it on here as a contraindication, but palliative care provided under physician supervision, okay? If it's guided by their physician, it's oftentimes well recommended for us to treat patients that have malignancy because it's soothing, relaxing. You're not going to spread their cancer in a case like this, okay? But you just want to make sure that they're medically managed. Considerations or precautions. Pregnancy, menstruation, abdominal aortic aneurysm, diverticulitis, severe arteriosclerosis, IBS or inflammatory bowel disease, recent abdominal surgery, irradiation of the abdomen, pelvic DVT or history of, and the presence of clot-preventing devices like the Greenfield filter, and unexplained pain. Indications for treatment are lymphedema, primary or secondary, phlebolymphostatic edema, which is that combined case, post-surgical or post-traumatic edema, and lipolymphedema, lymphostatic encephalopathy, complex regional pain syndrome, dependent edema, which can be related to paralysis, and systemic disease causing edema like rheumatoid arthritis or scleroderma. Your most common symptoms, as I mentioned a little bit before, the presence of edema. This is generally a distal to proximal presentation. Pitting is reduced in these cases with lymphedema. The skin is becoming fibrotic, okay? You have a positive stemmer sign. You pull at the skin and it's not pulling with you. A squaring of the toes and a buffalo hump on the dorsum of the foot. You see this just kind of ridge or bump across the top of the foot. Asymmetric between extremities. This heaviness and ache is the most common complaint. Not pain. Now, not pain is a lucid term. I have a lot of patients that do have pain, and actually, interestingly enough, once I start getting a significant reduction in their leg with the volume, I oftentimes will see an increase in pain. It's usually a pretty rapid decrease after that, but initially when I see that volume reduction, there's so many changes happening in a patient's limb that they have some pain associated with it. And discoloration of the skin. Understanding the stages. Stage 0, latency. You don't notice anything with this patient, but the patient is at risk. The transport capacity is subnormal, yet their system is able to manage the lymphatic load. This is when patient education is most key. All right. Stage 1 is reversible stage. Soft tissue pliability without fibrotic change. There is pitting. It's the most difficult stage to diagnose and differentiate from other issues. Okay. This will progress. Lymphedema always progresses. Okay. Stage 1 patient generally is like, I notice some swelling as the day goes on. I elevate my leg, I wake up in the morning, maybe it's not as bad, or it just feels a little tight or band-like. Stage 2 is irreversible. Pitting is reduced, the skin becomes fibrotic. It has a positive stemmer sign. This requires complete decongestive therapy to achieve your volume reduction. Stage 3 is your lymphostatic elephantiasis. These are these patients that you see just struggling to get around. Their limbs are drastically increased in size. Okay. Severe volume changes, you're seeing papillomas, cysts, fistulas, the skin folds are deepened, and volume can still be achieved, though, with complete decongestive therapy. Okay. When should a patient be referred to a lymphedema specialist? At any stage, including stage 0. Okay. Patients at least need to be educated on what they need to be looking out for. If you can capture lymphedema in its earliest stages, it's much easier to manage. Okay. If you're treating them later on, once you get to stage 2, it's just much more difficult for patients. How to refer. Lymphedema, the ICD-10 code is I-89.0, and our first evaluation includes assessment, history, review, measurements, goal setting, and then a lengthy education for patients. Okay? We usually discuss the details of treatment and supplies that are required. I usually put together an order form for patients, and I give it to them, and this is what they need to get before treatment, and once they get it, we start. The average treatment session is an hour or an hour plus, depending on the complexity. The key to understand here is, though, patients usually are seen 4 to 5 times a week. Okay? On average, I see people at 3 to 4 times a week, and then we taper as appropriate. The other consideration, there's not a lot of certified lymphedema therapists. So this doesn't mean you're just treating people in town. I have people that are traveling upwards of an hour just to come and see me. So now a patient is being treated 4 times a week, and they've got to travel over an hour. Oh, and they've got these huge edematous limbs. So, okay, so I'm wrapping their arm or I'm wrapping their leg. So maybe they can't drive. All right? Now they need to have a driver. There's a lot of considerations that go into planning a patient's care with this. Okay? And that's it. That's all I really have to offer as far as that. But questions?
Sometimes we have patients who come to us in acute care.
Yes.
And they place in sequential pumps.
Yes.
How do you feel about having those pumps on those patients' legs when they have?
Pumps are the best, worst option. Okay? If you saw the Sharknado movie, it says the best, worst movie ever made. So I always explain that to patients. It is your best, worst option. The gold standard is manual lymph drainage and the compression garments, compression bandaging. But if patients don't have that, a pump is still better than nothing. Okay?
So it's not detrimental to that.
Oh yeah, sequential pumps are important. We prefer pumps that are going to basically treat, if we're treating a leg, or treating the thigh first and then the leg. Okay, most pumps that are designed nowadays will do that versus just a pump that just pumps up and fills up. Okay, the concern with the pumps is, all right, you put it on a leg or you put it on an arm, it generally stops there. With manual lymph drainage, you're clearing the abdomen, you're clearing the venous angles. So that's why it's still the gold standard. But I do have patients that I put into pumps, maybe those patients that maybe they can only get in to see me twice a week. So the other 5 days a week, I at least have them using a pump at home. So I don't discourage the use of pumps. I encourage it, especially once patients are discharged for home, but I also encourage them to be evaluated and assessed for having manual lymph drainage and the compression bandaging as well.
Yeah, these are generic pumps, not specifically designed for
Yeah.
DVT preventive pumps. We kind of back and forth because, I mean, they're low pressure technically, but
Yes.
that would be something to do.
And the problem with those is generally it doesn't include the feet, right? I mean, it generally kind of stops
There
here.
could be a feet pump too, but
Okay.
usually it's just the way.
I mean, if they're to be used, it's best when it includes the feet, okay? Because all you're doing is you're compressing, you're going to just be pushing fluid down, you're going to be pushing fluid up. They're not clearing, so you're essentially just pushing fluid into other fluid, okay? In some of those cases, it might actually cause them more pain. I'd say if it doesn't cause them pain, you're not hurting anything, but you're not, based on with the current research where you're at, you're not really helping anything, okay? You're just kind of pushing fluid around a little bit, but you're not really clearing out of the extremity. Yeah.
How far are you booked out?
How far am I booked out? Right now, it's about 60% of my caseload. I've done orthopedics for 13 years. I've been doing lymphedema for the past year, okay? So it's a priority for me to get those patients in. So I'm getting patients in generally within a week, okay? We've just started this program more on the western side. We have 4 offices throughout St. Luke's network. Our Anderson campus, we have somebody who sees upper extremity only, okay? Our Emmaus office sees lymphedema patients. My McCungie office sees lymphedema patients, and our St. Luke's North. I know Sharon's pretty backed up at North.
Yeah, she's pretty.
Yep.
What
Yeah.
does she carry?
She's at least
Like 4 months.
Yeah.
Yeah.
So, and that's kind of where the general backup is, all right? Since we're just more establishing the program, I've been extending my hours and working longer days just to get these patients in because it's a priority. So I'm trying to at least get 1 to 2 patients in a week, okay? So generally there's about a week time frame till I can get them in. But it's a priority for me to get them in.
That's good to know, just because we have the 2 resident experts in home health
You're
right here.
coming
These
They're coming your way so that they're not our way.
We'll be happy to accommodate. And then the other thing is, flyer will be going out throughout the network. McCungie Institute over off Route 100, July 31st, I'm giving a presentation at 7 o'clock Monday evening on lymphedema. It covers some of these basics, the science for patients. It's dumbed down to a little bit more, and it's really going to be the onset of kind of a quarterly series I'm going to be doing for patients. Because some of these patients, they really want to know, they want to understand it. And, you know, you Google things, there's a wealth of information, but a lot of it's misinformation, okay? And when I gave a presentation for a physician group that I work closely with, and after the presentation, one of the doctors I know for years pulled me aside, "Can I talk to you a minute?" I said, "Yeah." I said, "What's up? You have a patient?" I said, "No." I said, "You know what? I have lymphedema." And he didn't even fully realize, and he went to vascular, and I said, "Well, they didn't really accomplish much for him." And he was sitting there through my presentation halfway through. He said, "I'm checking all the boxes," and there it is. So he came over, I evaluated him, and it was related to a childhood cancer issue and some complications. And yeah, he has lymphedema. So some of these patients, they don't even realize.
Another question, if you have like a mild case of lymphedema,
Yes.
say you end up in the hospital and they're pumping you with fluids and stuff, can that exacerbate it and make it worse?
Filling you up with fluids is, so I'll kind of backtrack. A lot of patients, they go to their family doctor, and a lot of patients, when they come to me, guess what? They're on Lasix, okay? And initially, they take the Lasix, and it helps. They see a reduction in the edema, but then it comes right back. So what do? They up the dosage of Lasix, and it eventually is just not helping anymore. Maybe it helps a little, but it's really not resolving the issue. And I see a lot of those cases, okay? So patients then come to me, and they say, well, should I still take my Lasix? I have this patient right now. We've gotten so much fluid. I've literally, in 1 week, I've gotten a 10-centimeter girth reduction in her leg, okay? That's tremendous. She's a very, very large woman, and she had serious lymphedema issues, but that's huge, okay? And she said, I'm concerned. She's lost 18 pounds since I started treating her. This is how much excess fluid she's been carrying around. I'm concerned I'm going to get dehydrated, she said. And I said, well, take your normal intake. I encourage patients to drink water, and really, even when I was going through my coursework, I was thirsty. I was more thirsty. You're promoting increase of fluid throughout the body. So it's important that these patients actually stay hydrated. I don't want to discourage them. There was a horrific case I was reading. I follow some of these discussion boards for patients to really understand where they're coming from. There was a woman that went and her doctor told her, just stop drinking all fluids. Don't drink any fluids. You have too much fluid in your system. I mean, wow. No, because now you're dehydrating other systems in your body. So I encourage patients that fluid intake is important. You don't really want to reduce it or change it, okay? The type of fluid you have in lymphedema, again, is that high protein, okay? And that's the thing. Lasix will remove the water, but it leaves the protein, okay? Your lymphatic system has to remove the protein. What binds to protein? Water, okay? But by maintaining fluids, okay, you're just maintaining a homeostasis for the body. You're not really going to hurt them that way, okay? Does that answer that? Somewhat, yeah. Any other questions? Anybody? All right. Thank you guys. I appreciate it.
Thank you guys very much. Make sure you sign in. And if you're from New Jersey, make sure you sign out. And if you're watching this online, please make sure you email me for your quiz. Thank you very much for coming.
Thanks.